Thank you. Hi, everyone. It's nice to be with you today. I am going to be discussing the Medicaid Spenddown. Please feel free to send questions as they arise. I think this topic can often be kind of confusing and technical, so I'm happy to answer questions along the way. I am going to leave my PowerPoint open like this because I have some notes that I'm going to reference, so hopefully that won't be too bothersome for everyone. Okay, so with that, we're going to discuss the Medicaid Spenddown. And okay, so first, just what is a Spenddown? And a Spenddown is often referred to as surplus or excess income. So you may be familiar with it depending on how folks have used it with you. But surplus, excess income, Spenddown is all the same concept. And it is the amount by which a non-MAGI or a DAB Medicaid consumer's income exceeds the Medicaid income level for that consumer's household size. So adults who have a disability, are blind, or 65 or older might qualify for the Medicaid Spenddown program, even if they're over income for Medicaid. Of course, that Medicaid applicant or recipient has to be eligible for Medicaid, putting the income aside, so they still have to meet criteria for residency. They have to be within the resource limit. They have to have appropriate immigration status. But putting all that aside, if their income is over the limit, they are able to access Medicaid through the Spenddown program. And if you submit a Medicaid application, it may be approved with a Spenddown, and the local district will approve that application, giving it what's called authorization for Medicaid coverage for 12 months. And now that is different than having active Medicaid coverage. So that's an important distinction. The Medicaid coverage is not active until the Spenddown is met. And we're going to discuss how to meet that Spenddown and activate the Medicaid coverage. Okay, so how's the Spenddown calculated? There are particular income disregards that can be applied to someone's income. There's always a $20 unearned income disregard that will be deducted from someone's unearned income. There are some Medicaid applicants who are also working. So there are impairment-related work expenses. The total cost of those work expenses, let's say it's particular expenses for transportation to get to work, or perhaps a certain accommodation that's needed in the house, certain equipment that's needed. So that the total cost of that expense can be divided by 12, and then that monthly deduction will be disregarded from the consumer's income. There's also an earned income disregard, whereby the first $65 of earned income is deducted from someone's income calculation, and then the half of the remaining earned income is also deducted. So if someone is earning $165 a month, take off 65, you have the remaining $100, and only the $50 remaining will count as income. There's also deductions for third-party health insurance. Many times a consumer might, pay for a standalone dental plan or standalone vision plan for $25 a month. That can be deducted for as an income disregard. And then the Medicare Part B premium may also be deducted from someone's income, unless, of course, they're MSP consumer and that premium is being paid for already by the state. So essentially, you're taking all sources of gross income, employment income, Social Security income, perhaps pension income, adding them all together, subtracting income disregards, and then you get the net available monthly income. From there, you'll be subtracting the Medicaid income limit from the NAMI, or the net available monthly income. And what's remaining is your Spenddown amount. So I have in the notes section just an example. I figured it'd be worthwhile to put it in real numbers. Our consumer Danny earns $14.75 a month in SSD income. Danny does not work, lives in a household of one. Danny has a standalone dental plan that costs $25 a month. Danny is 67 years old, receives Medicare. Danny is not in a Medicare savings program. So what we do is we take $1,475 of the SSD income, subtract $20 for the unearned income disregard, and then subtract $25 for that standalone dental plan premium for $25 a month. And then you'll subtract $148.50 for the Part B premium. And Danny's NAMI is now $1,282 essentially. From there, you subtract the Medicaid income limit for a non-Magi household of one. So $1,282 minus $884. And Danny's excess income amount will be $398. So if Danny wants to access active Medicaid coverage, Danny has to meet this $398 spend down amount. And we're going to talk about how to do so. Catherine, just wanted to see if there are any questions on just how to calculate the spend down.
No questions so far.
Okay, great. So how to meet your spend down? There is a pay-in program, and then there is the ability to submit bills, either paid or unpaid bills. And then there are other options. So it may not make sense, and we will go through this, it may not make sense for someone to actually meet their spend down to activate Medicaid, and there might be other options for those individuals. So I've just listed here what those are, which is the MBI WPD program, the pooled trust, the option to open a pooled trust. Consumers who are on managed long-term care and have a spend down have a different process, which we'll discuss. And there's also an interplay between the spend down program and extra help, which we'll go over. And then there's the possibility of foregoing Medicaid altogether because some other options might make more sense to a consumer. So option one, the pay-in program, consumers may prepay their spend down amount to the LDSS. They can do so for 1 to 6 consecutive months of their spend down. So if they cover 1 to 5 months of their spend down amount, they will have outpatient services covered by Medicaid. If they pay 6 months, then they will have not only outpatient services covered, but also inpatient services covered. And you'll want to check with your local district for the method of pay-in. I can speak directly to New York City's HRA program, which is that they accept check or money order with this form, the MAP 931B, which I have pulled up here. So you'll want to send, the check or the money order with this agreement. In this agreement, you can identify if you want to cover for 6 months of your excess income, 3 months, or on a month-to-month basis. And you have the opportunity to explain when it is you want the coverage to begin on the first of the month of, and the consumer can write that in. Sign it, date it, and send it back. For New York City consumers, they're going to send it to DARB. And we suggest that it should be mailed by the 15th of the month prior to the month of requested coverage. So if you're paying in, you want coverage to start, let's say August 1st, that the amount due and the form should be mailed by July 15th or before, really. Okay, now other way to meet your spend down is to submit bills related to medical expenses. What's important to note here is the bills, they have to be for medical expenses, so they can't be bills for other needs or other services. The bills can be paid or they can be unpaid. Depending whether they're paid or unpaid, will direct you as to how to submit them and how they how a consumer is able to get coverage. So we'll go into that. So the bills may be submitted to the local district to meet the spend down. The bills have to include consumer's name, the date of service, cost of service, what it is that, what service it is that the consumer got, and then if it is paid, the date that it was paid. The bill has to be faxed in by the first week of the month during which the consumer is requesting coverage. And this is important because by meeting the spend down earlier in the month, then a consumer has the opportunity to get other appointments in from other providers without having to meet the spend down again and without having to have out-of-pocket expenses. So sometimes an individual, knows that they have met their spend down in that month, and they're going to also go see maybe a dental provider and get a cleaning because they don't have to meet the spend down in another month to get that service. Okay, now the types of bills that can be used to meet a spend down can be bills from Medicaid providers. They could also be bills from non-Medicaid providers. They can be bills for non-Medicaid cover services, such as a chiropractor. I've had clients before get their spend down satisfied by a bill from for medicinal marijuana. So that's an interesting, I think, conversation to have, which is what is it that you actually, what kind of bills do you have? Do you have it for maybe some over-the-counter items that can be used to satisfy the spend down? The other types of bills that we're going to be discussing are bills called viable bills. They are unpaid medical bills that a provider is still seeking payment for, but they are a bill that is old, that is prior to the 3-month retroactive period for Medicaid. So, it's not going to be able to fall within that retroactive period and covered by Medicaid, but it will be able to offset future Medicaid coverage by satisfying the spend down. What's important to note about viable bills is that the consumer is still responsible for the entire payment of that bill. Okay, and we're going to talk a little bit more about viable bills. Bills for child services are able to be utilized to satisfy the Medicaid spend down. The thing about child services is those bills have to be submitted during the month that those services are being received. And child providers are able to submit those bills on behalf of consumers, so child provider can send that in directly to the local district. And then similarly, bills from public programs can also submit bills on behalf of consumers. So I have a client who receives psychiatric services monthly from an OMH provider, and this individual is essentially has that program submit every month his bill, and he always meets his spend down that way. So it's really a good way to ensure continuity of care for people who need to meet their spend down monthly. Okay, now obviously paid medical bills can be used to meet a spend down if they are greater than or equal to the amount of the spend down, giving coverage for either the current month and possibly future months. Again, bills submitted in the amount of 1 to 5 months of one spend down is going to ensure that there's outpatient services for those number of months that the spend down has been satisfied. And then again, 6 months worth of bills submitted will equal outpatient and inpatient services for 6 months. Now, if someone doesn't have inpatient services because they haven't submitted 6 months worth of their spend down amount, then inpatient coverage can still be activated at that point if they were hospitalized. Okay, so just a distinction on unpaid bills. There are recent unpaid bills that would be bills that fall within 3 months of your Medicaid activation. And then there are older unpaid bills or viable bills that I discussed that are essentially fall outside of the retroactive period. So they are 4 or more months before when your Medicaid has been activated. So recent unpaid bills can be used to meet your spend down as long as the provider is still seeking payment. And the bills will give you coverage for the months in which you receive that service. What's really important for consumers to know is when those bills are submitted to the spend down program, the consumer must still pay the doctor the amount of their spend down. So I have an example in there. Let's say you have your consumer has a spend down of $90. they submit a medical bill for $100 to the local district. Medicaid will activate the coverage, but Medicaid is only going to pay $10 of that medical bill. And the consumer will still be responsible for the first $90 of that bill. And then just to reiterate, for viable bills or older unpaid bills, those are bills for services that are 4 or more months prior to Medicaid activation. So they are falling out of the retroactive period. And they can essentially be used to satisfy a spend down, but Medicaid is not going to pay those bills. So they secure, sort of current and future coverage, but they're not going to, Medicaid is not going to pay that bill. So the consumer must still satisfy the debt to the provider. Okay, so if you have a client who is in managed long-term care, the spend down program is a bit different for them. So I wanted to draw out this distinction. In managed long-term care, the spend down is owed to the MLTC. It's not paid directly to the district any longer. The MLTC plan bills the enrollee for the spend down amount. And one thing that's important to note, a good protection for the consumer, is that the MLTC plan can't stop services if their enrollee has not paid the spend down. However, and we've certainly seen this, I'm sure some of you have, what the MLTC plan can do is involuntarily disenroll a member if they have not paid their spend down. Some protections exist for the consumer. The MLTC has to make a written demand for payment. They have to provide written notice, advance notice of the intended disenrollment. There are appeal rights here. There's a fair hearing right on involuntary disenrollments. So that's, while the plan can do this, the plan has to do it properly. And then the MLTC has to facilitate transferring the enrollee to another plan, and that's done by way of Maximus or New York Medicaid Choice. Importantly, the client has transition rights when they're transferred to the new plan, but what is at risk is that a client may not be able to keep their aides or their home care agency if the new plan that they've been transferred to doesn't have the same contracts. So that's problematic for consumers who might not be able to afford their spend down. They choose not to pay it, or they can't pay it. They are transitioned to a new plan, but their care may be disrupted. Okay, so we certainly wanted to talk a bit about COVID-19 protections and how the spend down program has been impacted. So the Department of Health basically stated that individuals who met their spend down in March of 2020 had active coverage extended for 6 months. And now I'm going to talk specifically about HRA because that is what I am most familiar with. I'd be curious to know if other local districts are doing things similarly. I'm hoping they are, but what we've seen with HRA is that in terms of authorizations, spend down clients are given a 6-month extension of authorized coverage at recertification. What's interesting to note here is that all other Medicaid recipients outside of the spend down program were given 12 months of active coverage at recertification, but spend down clients are only given 6 months. However, that's really not necessarily impacted their cases, because their cases have to remain open due to the COVID protections. So as the public health emergency has been extended, it continues to be extended. Additional 6-month authorizations have been granted. This is to ensure that no cases close because they can't close during the public health emergency. Now, regarding active coverage, there has been 6 months of active coverage granted if the client meets their spend down just once during the COVID emergency. So they don't need to meet it every month like they did when COVID wasn't here, prior to the public health emergency. So if a consumer meets their spend down just once or informs the local district or HRA that they've been unable to submit a bill because of the emergency, then 6 months of active coverage is granted. And then that active coverage is going to be extended an additional 6 months if it were to otherwise end. And again, the consumer need not meet the spend down again. So, you know, the idea is, one, to ensure that authorization extends, but then once that spend down is met at least once, active coverage is going to be extended for 6 months periods until we hear otherwise at this point. We have a link. I have a link there for more information if you want to see updates, HRA updates, those COVID protections. I think they do it monthly. And then if a consumer is having trouble meeting their spend down and they've tried to do so, they should just make sure that they inform the local district or the MLTC that they're attempting to meet their spend down. And that should be enough to satisfy meeting their spend down. I'm going to stop to see if there's any questions at this point. That can be kind of confusing, those protections.
So there is one question that came in. Someone asked, if someone has reduced income from spend down to no cost Medicaid, do they still report the change to HRA instead of MLTC?
So they're a MLTC consumer. I would say they should report it to HRA. HRA does the eligibility budgeting, and once that's noted in HRA's system, they should be communicating that to the plan. But you know, I've also been in a situation where I've had consumers report that to the plan and indicate to the plan that they should discuss that with HRA. I mean, HRA and the plan should have a direct line with each other, but it wouldn't hurt, you know, to sort of contact both parties.
Great. And Heidi, there was some feedback regarding the speed.
Oh, am I going too fast?
Yeah, they asked if it can be a bit slower.
Sure. Sorry. It's very hard because I can't see anyone.
Yeah.
So I have no feedback, but I appreciate that feedback.
Thanks, Heidi.
Sure.
And no more questions.
Okay. So, so I was saying earlier when I started that sometimes there are other options than meeting one's spend down to secure coverage that consumers need. Those options include the MBI WPD program, opening a pool trust, and then kind of taking advantage of the interplay between spend down and extra help, which I'll talk about in more detail. And then also foregoing Medicaid altogether because there might be some other options specifically for Medicare consumers. So let's talk first about the Medicaid buy-in for working people with disabilities, also known as the MBI WPD program. So this is open to individuals who are between the ages of 16 to 64. They're working and they have a disability determination. That disability determination can be either determined by the Social Security Administration or by the state. The state has a way of determining or deeming one disabled as well. And these individuals are eligible for Medicaid with higher income and higher resource limits. And so I've listed them here. I apologize, the limits here are for 2020, but I listed them here. And what's important to note about this program is that similar to the budgeting I talked about earlier, is that the first $65 of earned income is not counted as income, and then half of the remainder is disregarded as well. So, you know, number one, the limits are higher already than they are for other Medicaid recipients. And then a good portion of one's earned income is not even counted. So while a household of one has income limit of $2,659, in reality, that income is actually higher than $2,659 because not all of that consumer's income is even counted. So this is actually just a really wonderful program. It allows people to work and still maintain their Medicaid. And you know, it's just, I think it's a good program to have because it supports people being independent without worrying about losing their healthcare coverage. So I always like to think about this program for people who might be assessed a spend down, because if they are working, or maybe, you know, just a couple hours a week or month, and they're under 65, this might be a good option for them, and then they don't have to pay a spend down. The other thing that's helpful about the MBI WPD program is that there are grace periods. So a participant can request a grace period up to 6 months in a 12-month period. And those grace periods are granted because of a job loss or perhaps for medical reasons that limit a person's ability to work. So I know I've had clients before with chronic conditions that possibly flare up every now and then and may limit their ability to work. But if they ask for a grace period, they still maintain coverage, Medicaid coverage. They still maintain their place in the MBI WPD program, and they don't risk losing either, you know, they don't risk losing their Medicaid coverage. Just referencing COVID-19 easements for a second, there is a COVID-19 grace period. So anyone who experiences a job loss because of the public health emergency is able to be granted a 6-month grace period. And then they're also granted an additional 6-month grace period if they're still looking for new employment. So that's been helpful as well. Okay, so I think what's important to ask yourself as an advocate is trying to sort of figure out how to balance the need for Medicaid services, health services that might not be covered by Medicaid, such as vision, dental, or home care, and then compare that with what are the costs for the spend down versus the costs for consumers' out-of-pocket needs. And to kind of balance that and keep that in mind when having a conversation about whether or not it makes sense to satisfy a spend down. So does the client need Medicaid? Some questions that are helpful to ask is, you know, what is the amount of the client's anticipated spend down or current Medicaid spend down? Does the client have Medicare? Or really other coverage as well, I should include that. Does the client have home care needs? Are they already enrolled in managed long-term care or eligible for managed long-term care? Do they have extensive dental needs or vision needs? And then do they have any other high-cost needs that are not covered by other insurance or not covered by Medicare? So the consumer may have high out-of-pocket Medicare costs. So those are some of the things to keep in mind when making this analysis. Okay. So let's talk a little bit about pool trusts. And pool trusts are also sometimes called supplemental needs trusts or SNTs. And what they do is eliminate the client's spend down by essentially shielding the spend down amount or the excess income amount from Medicaid. So as long as the spend down amount is put into the trust, Medicaid essentially ignores that amount. And a trust is also helpful because not only does it make someone eligible for Medicaid, but it can also bring down someone's income level to the point where they're also eligible for the Medicare Savings Program. So that way a consumer, gets Medicaid coverage and then also stops paying their Medicare Part B premium. So it can be a very useful tool to save income and not spend that money by paying in their spend down amount to get Medicaid coverage. So the client has to deposit excess income into the trust each month. And there are certain federal requirements that the trust has to fulfill. A beneficiary has to be certified disabled. Again, that can be by the state or by the Social Security Administration. Trust money can't be withdrawn as cash, which is important to tell a consumer who's thinking about opening up a trust. And the money in the trust can only be used for the beneficiary. So a beneficiary can't, deposit their excess income and then purchase a car for their niece. That's not going to fly. That won't be approved by the trust. So the trust will, the trust has to approve the expenses. So that's just not going to be approved. And then the money left in the trust when the beneficiary dies reverts either to the state or to the trust organization. And that's important to know as well, because I often advise clients that if they are going to be using a trust, not to put, a ton of money in there beyond what they have to, and beyond what they're going to spend out on expenses. Because if there is a surplus in that trust and they don't get to use it before they pass away, then that money will essentially go to the state or to the trust organization. And I usually that's not what a beneficiary wants. The trust is also irrevocable, so it can't be dissolved. That's not to say that people can't stop utilizing it. A consumer can stop utilizing it if they want to, but the account will remain open essentially. Okay, so what does the trust do? It will reimburse for expenses. This is different than a spend down because the trust will reimburse for expenses beyond medical expenses, and that's important to know. So the trust will reimburse for any household expense you might have. It'll pay bills directly. Again, the trust will not distribute cash to someone, but often consumers will use it to pay, let's say, their rent monthly. It's best to use a trust for an expense that's paid regularly and that is the same amount every month. That way, the trust kind of figures out how to just get into a groove and pay that bill. And it's best if it's an amount that's either equal to or greater than the spend down amount. That way, again, there's no surplus or extra that's building in the trust. One thing that's important to note is that sometimes there are delays in paying bills. It's important that trust beneficiary keeps track of whether or not their bills are being paid, checks in with the trust to make sure that the trust knows what to do, and doesn't just kind of set it up and walk away. So there is a lot of paperwork involved. A trust is a complicated endeavor. And it does require organization. So you really want to make sure that your client has the capacity to be able to open a trust and maintain it. An S&T is also not free, which is important to know. There's an initial enrollment fee, and then there are, I believe, annual and monthly maintenance fees. There are a bunch of pooled trust organizations or companies that exist, and I've put a link here to a list of a few, certainly not all that exist, and they all have different fees and different costs. So it's important to kind of go through that and make a decision that's right for the client. Okay, So I am going to move on from trust. I'm happy to take questions on trust now if there are any.
There was a question regarding Spenddown.
Oh, okay.
Someone wanted to know if there's a limit in the Spenddown amount. For example, if someone is above the limit with $600, can they be eligible for Spenddown?
Yes. Yes, they could. It may not be a smart endeavor to pay $600 a month for Medicaid, depending on what that individual's needs are. But yes, they certainly could have a spend down of $600 and decide to meet it and activate their Medicaid.
Great, that was the only question that came in.
Okay. Okay. So I'm going to talk about spend down and how it can interact with extra help. So extra help, which you all may have already been trained on this week, I'm not sure, is also known as the low income subsidy, or LIS, and it covers most of the beneficiaries' Part D cost sharing. So their prescription cost sharing, deductibles, premiums, and Medicaid recipients who meet their spend down are deemed into LIS, and they don't have to file a separate application for it. And so why is that important? So essentially, if a consumer meets even just 1 month of their spend down in the months of July or later, they get extra help for the remainder of that calendar year and the entire following calendar year, which is essentially 18 months. If a consumer meets 1 month of their spend down in June or earlier, they get extra help for the remainder of the calendar year, which would be 6 months. And so let's say a consumer's cost sharing obligations for Part D are pricey. Then it might be worth meeting a high spend down, even just once, to lower those Part D costs for the rest of the either remaining year or the rest of the next 18 months. So I have an example in my notes section. Let's say a consumer's monthly Part D cost sharing is about $200 a month, and they have a spend down of $500 a month. If they meet their spend down just once, paying out $500 in July, then for the next 18 months, they save on their $200 a month cost sharing obligation. So they're basically saving $3,600 for total for 18 months by just paying out $500. If they meet their spend down in June only, then for the next 6 months, they save on that Part D cost sharing. So they pay out $500 and they save about $1,200 for the rest of that year. So it's a really good cost saving measure where it may not make sense for the Medicaid applicant with the spend down to pay their spend down every month, but it might make sense for them to at least meet it 1 month to deem them into extra help and save money on their Part D expenses. Okay, so there are other ways to think about saving a consumer's costs while providing services that don't necessarily entail activating Medicaid. So a consumer might choose to forego Medicaid because they can get what they need without paying the spend down. So this can entail just ensuring that the consumer has Medicare and is in an MSP program. Perhaps they apply for a Medigap plan or a Medicare Advantage plan. And then sometimes hospital financial assistance might be more worthwhile than perhaps submitting a hospital bill. So we're going to go over this in more detail. Okay, so Medicare and a Medicare savings program. So again, you may have already been trained on this as well. I think the Medicare training happened. So the Medicare Savings Program, there are 3 of them, QIMBY, SLIMBY, QI1. QIMBY is more comprehensive than SLIMBY and QI1. QIMBY covers Medicare premiums, and the client also cannot be charged for Medicare cost sharing for Medicare covered services that are delivered by Medicare providers. And QIMBY only may be a better option than Medicaid with a spend down if your client does not need home care and doesn't have extensive dental or vision needs. So I had a client who maybe earned like $11.50. She really didn't have the extra money to pay her Medicaid spend down, but she also didn't need home care, and she didn't have dental or vision needs that weren't already being met. And for her, you know, most of her services were Medicare services. She was seeing Medicare providers. So she did get bills every month that was Medicare cost sharing, but because she was in QIMBY, she didn't have any responsibility for those bills. And for her, it made sense just to remain in Medicare only and be in the QIMBY MSP program. So for her, it did not make sense to satisfy her Medicaid spend down. And then we move on to SLIMBY and QI1, which only covers Medicare Part B premiums. And SLIMBY only or QI1 only might be a better option than Medicaid with a spend down. If again, the client doesn't need home care, they don't have extensive dental or vision needs, and if their spend down amount is higher than the amount that they're going to pay out of pocket with Medicare. So again, it's this balancing of how much am I paying for a spend down every month versus how much are these bills actually going to be when I get a Medicare cost sharing bill. And if the Medicaid spend down is to the audience member who asked the question, if your Medicaid spend down is $600 a month, but your Medicare cost sharing is only maybe $100 a month, it doesn't necessarily make sense to pay that spend down amount. Again, if you don't need home care or dental or vision. So there's always this calculus that has to happen. And then the Medicare MSP program may also be considered in combination with a Medicare Advantage plan or a Medigap plan. So I'm going to go into those as well. So a Medigap plan is Medicare supplemental insurance. Medigap policies cover some of the costs of that original Medicare doesn't cover, so co-payments, co-insurance, and deductibles. And the consumer is paying a premium on the Medigap policy, so that premium is in addition to any other premium that the consumer is paying for their Medicare. So again, how much is that spend down amount versus how much am I going to pay for my Medigap premium? And there's a calculation that has to happen as to what makes more sense financially, what makes more sense depending on what the consumer's needs are. So Medigap plans, for the most part, don't cover long-term care. They don't cover vision or dental, nor do they cover, hearing aids, eyeglasses, etc. So, those high needs are not going to be met by a Medigap plan. So a Medigap plan might be a better option than Medicaid with a spend down if there's no home care extensive needs that are dental or vision. If the individual doesn't qualify for QIMBY. And then if the high out-of-pocket cost for Medicare covered services are less than the spend down amount. So again, like what is the cost comparison between the out-of-pocket costs and the spend down amount? What makes more sense to pay for the Medigap plan or to pay the spend down to ensure that there's Medicaid coverage. Okay, and then similarly, we have a Medicare Advantage plan known as Medicare Part C. Medicare Advantage plans combine Medicare Part A, B, and D, all in one private plan. Most of these plans do not cover long-term care, but some of them do. Some of them have some form of dental or vision care, some form of eyeglasses and hearing aids. I haven't seen Medicare Advantage plans that have extensive coverage of those, but if your client doesn't need that extensive coverage, then a Medicare Advantage plan might be just fine for those needs. A Medicare Advantage plan will also limit the providers that a consumer can see. So you have to maintain within your the plan's provider network. And then, the premium amount that a consumer pays and the cost sharing certainly differs among Medicare Advantage plans. So consumer has to shop around to see which plan is right for them. And Medicare Advantage plan might be a better option than Medicaid with a spend down. If the Medicare Advantage plan covers home care, dental, vision, and other needs that the client has, and the out-of-pocket costs for the Medicare Advantage plan is less than the Medicaid spend-down amount. So similar to everything else, it's a balance of what are the costs, what are the needs, how much is my spend-down amount, how much is it to pay the premium for the Medicare Advantage plan, and possibly continue to pay out of pocket for other needs that might not be covered by the plan. Okay, and then lastly, just a reminder that hospital financial assistance program does exist. All hospitals in New York have to provide this assistance to all patients who are uninsured residents of New York State. Their incomes have to be under 300% of federal poverty. This is regardless of immigration status. And there are some hospitals that will provide more assistance to individuals who earn upwards of 300% of the federal poverty level. So it's always worthwhile to see what kind of assistance one can get. While financial assistance application is pending, hospitals can't issue bills or collection notices. And then, for non-hospital providers, you can always ask them to either forgive a portion of the bill or all of the bill, or to forgive Medicare copays. Medicaid won't often pay above the Medicare amount anyway. So if let's say the consumer did have Medicare and Medicaid, the provider would still be receiving the same amount of payment, whether the client had Medicaid or not. So it's worthwhile to talk to the provider to see if they'll forgive the balance after Medicare pays. And why this is up here is because sometimes it might be more beneficial than paying your spend down to activate your Medicaid to see if you can get perhaps the bill reduced or forgiven before having to pay out your spend down. Okay, so I know that was a lot of information. I'm happy to take any more questions that there might be.
Sure, a question came in. Someone wants to confirm, spend down does not cover home health aid services. Is that the case?
Well, if individual is in it has been approved for Medicare long-term care, so they are then approved for home care, and then the spend down would need to be satisfied by paying that amount to the long-term care plan. So that question is, the answer is, I can't remember how they phrased it, but paying, basically to get home care, you have to be, determined eligible to receive those services, and then yes, you can satisfy the spend down by paying that to the long-term care plan.
Great. And then the second question, can someone have Medicare Advantage and also get Medicaid spend down?
Can someone also have Medicare Advantage and then also get Medicaid spend down? Yes. Yeah.
Great. I don't see any other questions, but Heidi, is it okay if I share your information in case any other questions come up?
Absolutely. Yes, you can share my information. People can get in touch with me directly. Also, if there are referrals, I have up here the Health Law Unit's referral email. And then if you're referring consumers directly, our helpline right now, it's limited hours because of COVID and our reduced staff, but you could tell your clients to call on Tuesdays between 10 and 3, and they'll go through an intake.
Thank you so much, Heidi. I really appreciate it.
My pleasure.
Information. So that concludes day 3 of the intensive, and we have one more day, not counting the Salesforce recordings that need to be watched. But I won't see you all, but please join me tomorrow morning for the last live June intensive training day at 10 a.m. and that will be Medicare Part 2. So thank you, everyone. Have a great afternoon.